We'll start again. For posterior defects of the mandible, we have to keep in mind that the inferior alveolar nerve is very close to the crest. If it is in proximity to your implant placement site, there are options available to us, which include nerve lateralization with or without grafting and tunneling with placement of a bone graft. So in the next couple of slides, we will discuss most of the commonly performed procedures among the ones that I have just enumerated. So alveolar augmentation, to those, if there's a doubt, is frequently required to restore volume lost as a result of disuse atrophy, either acquired or congenital, dentoalveolar trauma, infection, periodontal disease, traumatic extractions, and previous failed implant extractions. Now, before we start with any grafting procedures, there are these three terms of bone physiology that you need to know. They are osteogenesis, osteoconduction, and osteoinduction, right? The difference between the three should be clear to you. Osteogenesis is the process that occurs when surviving osteoprogenitor cells within a grafted material differentiate into osteoblasts and form new bone within the recipient site. The only graft material which is available to us, which is capable of osteogenesis, are autogenous grafts, which means that grafts which we have raised from the same person, the patient that we are operating on, right? The next term is osteoconduction. It occurs.
Implant site चल रहा है online है. Dr. Meghna Kumar है.
Yes, sir. I can't hear you, sir. The volume is very low. I'll try to raise it just a second. Hello, sir. Let's continue. Osteoconduction. This process occurs when grafted material functions as a scaffold for the ingrowth of vascular tissue and mesenchymal cells from the recipient site. Bone apposition occurs within the graft site, and the grafted material is eventually resorbed and replaced with viable bone. All of these examples are capable of osteoconduction. The third term that you need to know is osteoinduction, which involves new bone formation through the recruitment and stimulation of recipient site osteoprogenitor cells using bone growth factors transplanted within the grafted material. So these are basically synthetically manufactured materials. For example, recombinant human bone morphogenetic protein, which we can add to our grafts or place over our barrier membranes to induce or to stimulate osteoinduction, right? Now, Mish has given us these 11 surgical keys to grafting. Any of the grafting procedures we may plan to perform, which we will study about later, the prognosis or the success of these procedures depends on how well you follow these 11 surgical keys, right? So we will very briefly go through them. The first is surgical asepsis or absence of infection in the recipient site or the site in which you are placing your graft. Any periapical infection will lead to a very low pH, almost a pH of 2. This causes a solution-mediated resorption at the apex of the bone of the patient, as well as any graft material that you may place. This leads to insufficient bone formation and eventually failure of the graft. Also, there is no initial blood supply to the graft, right? Any foreign graft material that you're placing, or even an autogenous graft, a block graft that you're placing, there is no immediate blood supply. So the antibiotics that you're administering to the patients via an oral route or an IV route will not really reach the graft site for the first few days. So an excellent idea here is to mix parenteral penicillin or cephalosporin or clindamycin right into your graft material before you place it on the graft site or the recipient site. The second key here is soft tissue coverage and flap design. Primary soft tissue closure, watertight, is mandatory. A technique here, a submucosal, excuse the spelling, it is submucosal space technique described by Mish. We will go through it in the next slide where I have a diagram. The suture materials as indicated by Mish are vicryl and proline. Silk is actually contraindicated for grafting procedures. Why? Because as the soft tissues begin healing and the flaps begin to retract, silk does not give us adequate pressure. Vicryl can be used for about areas where we have a small amount of grafted material. For larger grafts, proline is indicated. The suturing technique, if we are giving suture, if we are giving simple interrupted sutures, they should be at a distance of 3 to 5 mm apart and can be interspersed with non-locking continuous sutures. Horizontal mattress sutures can be given in areas where there is greater tension. Another practical tip given by Mish is that once we are complete with all the treatment, once the suture has been given, gentle pressure for 3 to 5 minutes should be applied on the grafted site, and milking of the soft tissue should be done so that any blood which has accumulated and may lead to formation of a dead space can be removed before we send the patient back. So this is the submucosal technique described by Ish for mucosal flap advancement for defects greater than 5 mm. As the PG students would know, usually our usual method of advancement of flap is scoring the underlying tissue multiple times with the blade. Here, no, that technique suffices, but only for defects less than 5 mm. For defects larger than that, we raise a full thickness facial flap, not beyond the mucogingival junction. Once the full thickness flap is raised, we take our surgical blade and give one single incision through the periosteum, at least 2 to 3 mm above the mucogingival junction and parallel to the crestal incision that we have given. Next, we take our soft tissue scissors or our medicine bomb dissecting scissors and tunnel a submucosal space up to 1 to 1.5 centimeters beyond the first incision that we have given. This tunnel can also be extended on either side of the vertical releasing incisions. We gently manipulate the flap, advance it, and that gives us coverage of greater than 5 mm. The next key is space maintenance. Collapse of space under the barrier membrane may impair desired size and contour. For space maintenance, we can use a fixation screw or a titanium reinforced mesh or graft material beneath the membrane till the level of the desired bone volume. Mish here suggests the barrier by bulk concept, where he suggests over contouring with resorbable alloplast by several mm. Right, so these images here show us fixation screws, also known as stent screws. We want horizontal augmentation up to this level. So we've placed the fixation screws up to that level and we've packed the area with graft material. This will be covered by a barrier membrane and the soft tissue flap will be approximated and closed. Next, graft immobilization. This ensures initial blood clot adhesion with its associated growth factors. No load is to be placed on soft tissue over the graft. If the barrier membrane or fixation screw become mobile, fibrous encapsulation occurs. And therefore, to immobilize your graft, use a tent screw, use a block graft with fixation, or use a transitional fixed prosthesis. Next is the phenomena called regional acceleratory phenomena. This is your tissue's response to noxious stimuli, which may include any surgical procedure, any fixation, any periapical infection. This causes faster tissue regeneration than normal, and we can induce it by decortication using drill holes 3 to 5 mm apart, right? Decortication has other benefits. It improves the trabecular bone supply, it expedites revascularization, and brings in growth factors. Next, our success of the bone graft depends on the host bone blood vessels. We should decorticate the cortical bone before placing graft for the reasons I just mentioned. Bone from below the graft grows faster than fibrous tissue from the overlying tissue if we have decorticated the cortex sufficiently. Next, growth factors. These include your platelet-derived growth factors, your transforming growth factors, your PRP, and your bone morphogenetic proteins. Now we have 4 ways to introduce growth factors into our graft site. One, we can simply prepare PRP during your procedure and place it on the grafted membrane. 2, you can use autologous bone in your graft site. For example, chin graft, ramal graft, because these pieces of bone have all these growth factors stored in them and will release them into the graft site once placed. We can use allografts such as demineralized freeze-dried bone, and we can induce the regional acceleratory process. Next, bone morphogenetic proteins. Already explained, these induce mesenchymal cell differentiation into chondroblasts and osteoblasts. Healing time, it is imperative to ensure that during the healing time, there is no movement on the soft tissue or on your graft. 4 to 6 months indicated when graft volume is less than 5 mm. 6 to 10 months of healing time indicated when graft volume more than 5 mm. And for dense bovine calcium materials, almost 2 years of healing time may be required. Defect size and topography plays a role in the success of your graft. The larger the defect, the greater is the autologous component that you will need. A 5-wall defect or your extraction socket is an ideal site for new bone formation. As you move to 4-wall defects or 3-wall defects, you need to bring in new materials, new grafts, new ways to make the topography work in your favor, right? A transitional prosthesis should be given during soft tissue healing and maturation. This favorably affects soft tissue closure and helps in space maintenance and mobilization of the graft. Now, the first procedure we discuss is guided bone regeneration. This is a procedure which involves the placement of a cell-occlusive physical barrier between the connective tissue and the recipient site, right? So Wang et al. In 2001 gave us these 5 very important features of your guided bone regeneration procedure. Cell exclusion, which means that it prevents growth of soft tissue cells, connective tissue, or any other epithelium tissue into your recipient site. Tenting, or as we mentioned, or as we discussed earlier, space maintenance, scaffolding, stabilization, and a framework, right? So the concept is that we place a barrier membrane directly over the bone defect and under the soft tissue, including the periosteum, before primary closure. The procedure aims to stabilize the blood clot, prevent growth of soft tissue cells into the bone defect, and allow spaces maintained over the defect to be filled with bone-free genital cells only that may develop bone uninhibited, right? Does anybody have a doubt with this procedure? No? Has everybody understood GBR, the concept of GBR? No. Next, alveolar distraction. It is indicated in moderate to severe vertical alveolar bone defects, in segmental deficiencies, in narrow alveolar ridges, adjuvant to other bone graft techniques, for gradual vertical movement of ankylosed teeth, and for gradual vertical movement of an osseointegrated implant together with the surrounding alveolar bone. Now, the process of alveolar distraction has a couple of phases. The first phase is your osteotomy, where you will use your surgical instruments or your burr to create the osteotomy that you desire. For example, in these diagrams, because we require vertical augmentation, the osteotomy cut has been given horizontally, right? A vertical distractor has been placed and fixated. The next phase is the latency period. It is mostly 7 days. Extended latency period of more than 15 days can be applied to ensure complete revascularization of the transport segment, in which the mucoperiosteal pedicle is small or endangered. The next phase is the distraction phase. The distraction rate advised here would be 0.5 mm per day. And the last phase, once your distraction is over and once you have received the desired vertical augmentation, you will send the patient into, or the patient will be put into consolidation phase. This will allow for maturation and corticalization of the regenerated bone. The mean consolidation period is 12 weeks. So to just come back to this diagram here, we need vertical bone augmentation. We've given a horizontal osteotomy cut, placed a vertical distractor. Once the latency period is over, we start with the distraction 0.5 mm per day in the required rhythm. Gradually, we see here that the vertical or the height of the mandible, the posterior mandible, has improved. The consolidation phase starts here. Once the consolidation phase is over, the distractor can be removed and the implants can be placed into the vertically augmented posterior mandible. Next, we move on to sinus lifts. Sinus lifts, I'm sure you all are familiar with, so I will move on very quickly. An indirect sinus lift or a lift through the alveolar ridge is indicated when the residual alveolar bone height is 6 to 8 mm. The technique begins with a pilot burr to mark the implant site. A 2 mm twist drill prepares the osteotomy 1 to 2 mm short of the sinus floor. A final osteotomy width is sequentially obtained, remaining 1 to 2 mm short of the antral floor. This instrument is known as an osteotome. This is a curved osteotome. There are also straight osteotomes available. A flat-ended osteotome, the same diameter as the final osteotomy size, is used within the site. A surgical mallet is used to gently and slowly tap the osteotome 1 to 2 mm through the sinus floor. The osteotome raises the floor and 1 to 2 mm of bone within the sinus mucosa over the implant site. An implant is then inserted into the osteotomy and extends 0 to 2 mm above the surgical sinus floor without any breach of the sinus membrane. Right? A modification of this technique is a balloon sinus lift, where instead of an osteotome, we use a latex balloon, which is connected to a catheter. It is inserted into the same osteotomy site through your through the opening that you've made using a round burr and inflated, raising the sinus membrane to quite a considerable height. It is then deflated and secured into the osteotomy site, inflated again with normal saline, then slowly deflated and retrieved from the osteotomy site. Allogenic cancellous bone and marrow particulate graft was filled under the elevated sinus membrane using bone condensers. The next kind of sinus lift, direct sinus lift, where which is indicated when the residual alveolar bone height is less than 5 mm. So what we do is we create a window through the lateral wall of the maxillary sinus, raise your sinus membrane, place your graft and your PRP, PRF, whatever material you have chosen for that patient, into the floor of the sinus, pack it nicely under the space created in the space created under the membrane, and then after a satisfactory healing time, place the implants, right? The next type of augmentation procedure we will discuss is block grafts. Intraoral block grafts can be taken from two sides, the chin and the ramus. Extraoral grafts can be taken from the iliac crest and from the tibia or from the fibula, right? The most commonly site which is used for augmentation and implant dentistry is the menton region of the chin graft. So here you have to maintain a margin of 5 mm from each mental foramen, 5 mm from the apices of the anterior roots, and 5 mm from the inferior border of the mandible. The most superior bone cut is made first because the position of this border is less flexible. You have to save the apices of the, otherwise you will end up compromising all of these teeth. The depth of the osteotomy should be at least through the outer cortex and to the opposite cortical plate, but not through and through. We just need the outer cortex and the underlying cancellous bone. The inferior margin has a cut perpendicular or angled upwards. So the block harvest may be lifted out of the jaw with an osteotome. This also may protect the inferior portion of the mandible from fracture during the harvest, because more cortical bone along the inferior border is maintained, right? If we cut perpendicular or angled upwards, we can save a little bit of a little extra bone towards the inferior border. So if you see in the first image, superior osteotomy cut well away from the apices, inferior osteotomy cut 5 mm from the inferior border. Both of these vertical cuts will be 5 mm from your mental foramen, right? You raise this cortical plate, and you can also harvest cancellous bone from this region, cover it with a barrier membrane, reapproximate, close. Okay. The second intraoral site is your ramal graft. Once you've given your incision here, the incision is similar to the incision that you give for your coronoidectomy. You go along the external oblique ridge. Your superior osteotomy is along the external oblique ridge. Your anterior vertical cut is usually at the level or near your first molar. After the vertical cut approximates the position of the inferior alveolar nerve, the cut is limited to the thickness of the cortical plate, usually 3 to 4 mm. The anterior cut is usually 10 to 12 mm. The posterior cut is usually above and lateral to the inferior alveolar nerve, in front of the lingula, on the lingual of the ramus. So the lingula is on the lingual side of the ramus of the mandible. Corresponding to it on the lateral side is your antilingular. So your posterior cut usually ends near the antilingula. The posterior cut may be full thickness through the cortical plate to the horizontal cut, because the nerve in this region is usually below or posterior. Right. So the one thing that you have to remember here is that this cut, the inferior cut, should not go through and through the cortex. Otherwise, you might end up damaging the inferior alveolar nerve. Right. Again, if you look at this picture, here is the external oblique ridge osteotomy. Here is the inferior cut, not through and through the cortex. These two cuts can go through the cortex. An osteotome can be used to separate the bone from the ramus, and it should always be held in a direction parallel to the ramus of the mandible. Graft is lifted, transferred to the recipient site, which here seems to be the posterior mandible. Now, to compare both of these sites, surgical access is better for your chin graft. However, the chin graft has some cosmetic concerns. In patients with a very prominent chin, it may lead to a slight depression in the menton region. Graft shape, we are able to harvest a thicker graft from the menton. Graft morphology, we can get both cortical and cancellous bone from your menton graft. Next, complications or donor site complications are seen more frequently with your chin graft. Extraoral autogenous donor bone grafts for endosteal implants. So block grafts include your iliac and tibia. Your vascular grafts include fibula, iliac crest, corticocancellous bone grafts. So the technique that they've described here is the subcrestal window technique as described by Beheri and Al-Sabai. This provides us with a bicortical full thickness graft while sparing an 8 to 10 mm bridge of iliac crest proximally. Right now, the anterior iliac crest is preferred because the posterior harvest is usually limited to 1 or 2 cortical plates, while the anterior iliac crest gives us a tricortical harvest. A 7 to 8 transverse incision is made either proximal or distal to the iliac crest. The incision must remain at least 2 cm lateral to the anterior superior iliac spine to avoid damage to the lateral femoral cutaneous nerve. An oscillating saw is preferred for the sagittal cut. A sizing guide is then taken as determined by the oral surgeon preoperatively. It is placed on the inner table and the size is marked directly onto the ilium. A second sagittal cut is then made. The area of the ilium where the bone thinks considerably is located and the bone is carefully osteotomized. Now, this is one procedure where we need a large, procedures where we need a large amount of graft. For cases where only a small amount of graft is required, the trapdoor technique is followed, where we don't remove any of the cortical bone. We simply use our burr to give drill holes to create a sort of a trapdoor. We lift the cortical bone out, harvest the cancellous chips from the iliac crest, replace the cortical bone, and then use the graft that we have raised. Tibial bone grafts, not very commonly used, so I will skip it so that we can move on to more important procedures. Repositioning of the inferior alveolar nerve. So as we saw in that flow chart, for a posterior mandible, if the bone is deficient, then we must always keep in mind where the inferior alveolar nerve lies. If this remaining height is very less, then it is indicated that we reposition the inferior alveolar nerve. So the first procedure that we will read about is inferior alveolar nerve lateralization. So an osteotomy is performed at the mental foramen, drilling around the orifice to obtain a ring of external cortical bone. A window also may be made extending about 5 mm ahead of the foramen in order to avoid damaging the nerve over its anterior curvature. An en-bloc osteotomy is then made at the external cortical level, or a posterior window is performed in the external cortical layer along the intra-bony trajectory of the nerve. In order to secure complete mobilization of the alveolar nerve, the incisor branch located about 5 mm from the foramen must be sectioned. Then, with the nerve fully lateralized, the dental implants are placed under direct visualization bicortically, taking advantage now of this mandibular basal layer, which we have suddenly gained access to. Once the implants have been positioned, the vestibular cortical layer is replaced, and those cases where an osteotomy has been performed, the nerve is passively placed in relation to the implant. So this is just to show you where the osteotomy occurs, or where we give the osteotomy. Here you will find the mental foramen in this region. Just behind it, right? The osteotomy is done. Along these marks, the cortical bone is removed. The nerve is isolated and reflected laterally, and it is in this space that your implants will be placed. So once again, this is the superior cut of your osteotomy. This is the inferior cut. The bone has been removed, exposing the inferior alveolar nerve. The nerve has been lateralized. The entire ridge has been exposed, implants placed, and prosthesis given. A modification of this procedure is nerve fenestration. In this case, neither dissection of the terminal branches of the nerve nor sectioning of the incisor branch is needed. The technique involves the preparation of a cortical window via osteotomy or drilling located posterior to the mental foramen. After carefully freeing the nerve, the latter is separated using a vessel loop, applying gentle traction towards the implants, applying gentle traction outwards as the implants are positioned. Finally, the vessel loop is removed and the nerve is replaced, positioning a resorbable membrane between it and the bone window to avoid direct contact with the implants. And procedure is completed by suturing the mucopharynx. So the only difference here is that you do not section off these terminal branches and only a window is created. An entire osteotomy is not done to remove the cortical plate of the vestibule. Right? So the limitation of this procedure is that if we need multiple implants in the posterior mandible, we cannot go for this procedure. We have to go for nerve lateralization. Right. Moving on to zygomatic implants. Zygomatic implants have become very popular currently in implant dentistry. Why? Because the zygomatic implant allows for establishing posterior maxillary support by using the limited crestal alveolar bone in the bicuspid region to stabilize the platform of the implant, and the zygoma for establishing initial stability of the apical portion of the implant, thus allowing for a quad cortical stabilization of the zygoma implant. So the zygoma implant basically depends on the zygomatic bone and the alveolar crestal bone in the bicuspid region to achieve primary stability. Right? It is indicated in severely atrophic edentulous maxilla, for maxillary reconstruction after partial or total maxillectomy, and for patients with systemic pathology such as severe maxillary atrophies. Contraindications are the same as for other implant procedures. One thing which has been added here is any pathology of the zygomatic bone, right? It has a couple of advantages. The first and the foremost being that it is a graftless procedure. Before the advent of zygomatic and pterygoid implants, any procedure which required placement of implants in an atrophic maxilla required extensive grafting, either in the sinus region or in the alveolar region. So there is no additional donor site surgery and morbidity. Since there is very good anchorage from tough zygomatic bone, it can be immediately loaded, or a fixed prosthesis can be given within 6 months. Right? Those are the main advantages of your zygomatic implants. These are treatment recommendations based on presence of bone in the different zones of the maxilla. Zone 1, 2, and 3, to just revise. Zone 1 of the maxilla is the premaxillary region from canine to canine. Zone 2 is the bicuspid region. Zone 3 is the posterior maxilla. So if there is bone present in all of 3 zones, we can use your traditional axial implants, which we have been discussing for so long. If bone is present only in zone 1 and 2, we can use your 4 traditional implants, or all on 4. Zone 1, if bone is present only in zone 1, the rest of the regions are atrophic. You can use zygomatic implants plus 2 or 4 traditional implants. Where bone is insufficient all across, we can use 4 zygomatic implants, or what is known as the quad zygoma. Right? So these diagrams will help you visualize exactly where the zygomatic implant enters. Problem, sir? कोई problem है? Right. So to allow direct, I hope the undergraduate students can visualize. This is the maxillary sinus. Can you understand? This is sort of a sagittal section. This is the anterior wall of the maxillary sinus. This is the floor of the maxillary sinus. So to allow direct visualization of the path of the drills and implant, the Schneiderian membrane may be removed or deflected. The osteotomy is completed at the maxillary crest as well as the zygomatic bone here, using a 2.9 to 3.5 mm drill. The shaft of a star grip driver must be perpendicular to the alveolar ridge, ensuring the proper orientation of the zygoma implant platform, right? Now, there are a couple of surgical approaches to place the zygomatic implant. Very briefly, this is the first, this is the most classical approach, or the first approach which was initially described by Brainmar. Here, as you can see, there is extensive soft tissue dissection. The incision given here is a Leafort 1 level incision in the vestibule. The entire palatal mucosa has been reflected, and the entire labial and buccal mucosa has been reflected up to the level of the infraorbital nerve, and laterally or medially to the level of the pyriform aperture, laterally to the level of your infrazygomatic crest, right? So this approach is no longer followed. This was done earlier because the zygomatic implant was placed via a palatal approach under direct visualization through the maxillary sinus by creating this lateral window in the posterior aspect of your maxillary sinus, right? This is no longer regularly done. More commonly used procedure is your sinus slot approach, right? As you can see, the orientation is not through the palate as earlier, because that led to a lot of prosthetic concerns. Here it is more through the alveolar crest. A similar flap is raised on the facial side, but palatal side soft tissue dissection is not as much. A slot is created in the sinus, right? By the purpose of this slot, once again, is to visualize your osteotomy drill and your sinus. This is the curvature of your zygomatic buttress. The superior most point or the superior extent of this curvature is the point where you will give your first drill using your micromotor with a straight fissure handpiece. You will then use a guide gauge, place it inside the opening that you have made, and try to simulate the orientation of your implant. You will then create an osteotomy window along the orientation of your guide and create the sinus slot. The third surgical approach for your zygomatic implant is this exteriorized zygomatic implant, where we do not go through the maxillary sinus. As you can see, this is in contact with the outer wall or the lateral wall of the maxillary sinus. It does enter the maxillary sinus, but very superiorly. The final and the most accurate method is by using stereolithography, not very commonly done because of limited resources. Last topic for today is pterygoid implants, also called pterygomaxillary implants. By definition, all pterygoid implants encompass the tuberosity region and engage the pterygoid plates. Restoring posterior maxilla using pterygoid implants is beneficial, as these implants are stable biomechanically and there is no cantilevering of contics. Has a very high success rate. Insertion of implants at the level of the pterygoid plate can be potentially associated with bleeding from either the maxillary artery or the pterygoid plate. So even though there are great advantages of this procedure, there are still associated serious complications. So it is always advised that this procedure should be performed by an experienced surgeon who is familiar with the anatomy of that region, right? So the three terms while preparing your osteotomy site for a pterygoid implant: under preparation, osteodensification, and bicorticalization, right? So you see here, this is an atrophic maxillary ridge. A mid-crestal incision has been given from this hamular notch to this hamular notch. Vertical incisions have been given, and palatal and facial flaps have been reflected to expose the entire crest. This is the region where you will make your first drill. Upwards and backwards in the direction of your pterygoid plates. The first drill should be a needle drill and it should go all the way through. it is advised that you take multiple radiographs in between to ensure proper orientation of your drill, right? Once your needle drill has gone through and you are sure that the pterygoid plates have been breached, you can start with sequentially increasing the diameter of your drills. The first 2 drills, clockwise direction, next few drills, anti-clockwise direction. Why? So that we can densify the bone in this region, right? The bone here is very porous. More density works in our favor. So we need to osteo-densify this region. The next concept is bicorticalization, which means that this pterygoid implant engages 2 cortices. One is this alveolar cortex, and one is your pterygoid plates, right? The pterygoid plates of your sphenoid bone, right? So this axial section of your CBCT shows you where the bicorticalization occurs. This is where it has engaged in the pterygoid plate of your sphenoid bone. The primary advantage of using pterygoid implants is that the density of bone in this area affords good anchorage potential, which may be superior to that of any other part of the maxilla. However, the main disadvantage is the technique sensitivity and difficulty in access for clinicians and patients, right? So that was all for today. Are there any questions? UG students? Postgraduates? No?